Let's give our presenters another round of applause. Dr. West, Dr. Vicente, Angela, thank you guys so very much. Mr. Lockett is going to introduce our panelists, but I'm going to ask our presenters if they'll come up, please. Dr. West, Dr. Vicente, and Mrs. Mull. And then we're going to add 2 additional panelists, Mrs. Kathy Hunt, if you will come up, and Dr. Cynthia Wilborn. And Mr. Lockett is going to introduce the 2 panelists, and then it will be time for question and answers. And I do appreciate you guys being so patient with us. I realize we're running a little bit behind, but if you will be patient, it's time now to get some information from 2 additional presenters. Dr. Wilborn. Oh. One other thing, if you will please, we have 2 evaluation forms, one for the Little Rock Black Nurses Association and the other one for Future Builders. If you have to leave, and I hope you really don't, please leave those evaluation forms. We really do appreciate it. Thank you for being patient. Mr. Walker.
Good evening.
Good evening.
I have the pleasure to introducing to you Miss Kathy Hunt, who is a native of Monticello, Arkansas. She graduated from Pine Bluff High School and she attended UAPB. She is the president of the Pine Bluff Mutual Sickle Cell Support Group, and she's held that office for about 3 years. Her role includes developing, coordinating, and implementing sickle cell support programs and providing help and assistance to sickle cell patients and their families. The Pine Bluff Mutual Sickle Cell Support Group conducts sickle cell education and awareness to schools, churches, and community organizations. In addition to being president of the Pine Bluff Mutual Sickle Cell Support Group, Mrs. Hunt serves as pastor of God's Elect Church in Pine Bluff. She is an elected member of the Dollaway School Board, where she serves as secretary. Let's give Ms. Hunt a hand. Dr. Cynthia Wilborn is a native of West Helena. She is employed by the Arkansas Department of Health as a community health nurse specialist. In this position, she is responsible for providing training and technical assistance to nurses in the Pulaski County schools. And she's been a nurse in the community for 16 years. Dr. Wilborn recently received her doctorate of nursing practice from the University of Tennessee Health Science Center. And let's give Dr. Wilborn a hand. Okay, now we'll proceed to our panelists. And as we said before, we'd like everybody to use their program. We have a note section in the back where you can write your questions down, and we'll be taking questions as soon as the panelists finish their presentations.
I have a question for Dr. Wilborn. Dr. Wilborn, I know that you work with the nurses in all 3 school districts in Pulaski County, which is Little Rock, North Little Rock, and Pulaski County School District. Could you give me an example of what the prevalence rate is of sickle cell disease in the schools?
For Little Rock School District, we have, at the end of this school year, we had 48 cases. For North Little Rock School District, they had 15 cases. And for Pulaski County Special School District, it was 18 cases.
18.
Yeah, 18 cases. And one of the nursing coordinators, Sandy Campbell, which has been in the school district for over 30-some years, when we met with her back here in September of 2011, and one of the health conditions that she was concerned with was sickle cell. She said over the 30 years that she has been in the school district, she has seen a more increase of complications and problems with sickle cell in the school.
The frequency of active cases.
Mm-hmm.
Would you ask that question again, please, so we can hear?
She said the frequency of active cases.
Oh,
over the
okay.
30 years that she's been in the school district.
So maybe there could be an active role in education prior to having children.
Right.
I'd like to ask a question, Dr. West. Dr. West, what are some of the negative health implications of giving children antibiotics at such an early age and for a prolonged period of time?
Well, that may be a better one for Dr. Sacinte, but I'm not aware that we've had a whole lot of problems related to the penicillin prophylaxis. It's a pretty narrow spectrum antibiotic. It's not like one of these big mecacillin, broad spectrum
So it's
deals.
broader spectrum.
It's generally tolerated very well, and unless you're allergic to it, most children take it. Do you still give it up to age 5 or 6? Or?
It would give it to 6. If you're allergic, we use erythromycin. But the spectrum's so narrow that if a child gets an infection, there's always plenty of other antibiotics we use. I don't have a lot of problems with this one.
I don't know which person this goes to, but all of my children, they have the sickle cell trait. They don't have the disease. But do they do any kind of counseling like you want to, when they get older, about, you don't want to have a partner that has the trait or the disease, so you won't have children with the disease? We did get that letter that they had the trait when they were born, but they always complain of like their legs hurt, but I just dismissed it and said, okay, you're growing or something like that. But when you show the bone things, it makes me wonder if I need to, would they not
I'm glad
have
somebody
that?
asked this question, because sickle cell trait is, there's several comments, I'm hogging the platform, but anyway, I'm glad you asked, okay? Because number one, sickle cell trait has gotten a lot of attention recently, and there's different, if you look, the American Society of Hematology has different recommendations from some of the other support groups, because there's been a statement coming out that patients with sickle cell trait should be excluded from certain sports, and people are worried, because of the rate, there's an increased risk with sickle cell trait in high intensity athletics or in military training. And if they don't stay hydrated enough, there's an increased risk of sudden death. And there's been a couple high-profile athletes who have died from sickle cell trait. Now, this does not mean for normal kids who are out running around wanting to play sports, that should be stopped. And so some of the medical groups are recommending retesting for sickle cell trait. Unfortunately, in many families, although every child is screened, by the time they get into high school, that information, not in your family, has not been passed down. And they actually did a study where they looked at college kids and college athletes where they rescreened for sickle cell disease and went back, or sickle cell trait, and they went back and said, oh, you have trait. And the young adults did not know they had trait. And so that was new information, but when they went back and spoke to their mother, the mom, oh yeah, I know that. But it hadn't been passed along to the child when they became responsible for their own healthcare choices. So sickle cell trait's a big deal. Because of some of the different recommendations from different healthcare groups regarding participation in athletics. The people who said that we shouldn't be testing so that people don't get excluded or discriminated against, recommend universal precautions, meaning, not dumping people out there in 102 heat and allowing people to drink more and take breaks. Number two, the answer to your question about the bone pain, that's in sickle cell disease. People with trait by definition have 49% sickle hemoglobin. They're not really at risk for the bone infarcts that I see in sickle cell disease.
And also along the sports line trait. They cannot get on the field, they can't practice, they can't do anything until they are cleared by lab testing that says they either have sickle cell trait or they don't. What most colleges, like I know U of A, UCA, ULR, this is what they're doing, is modifying just their training so that they are more well hydrated, more cared for, be careful in the heat, monitoring for pain and those type of things. And so that they prevent those athletes who do have sickle cell trait, they keep them from having any complications or the risk of death. The NFL and the NBA are also doing the same things to protect their athletes and modify, because this past year during the Super Bowl, one of the athletes couldn't go from the Giants because the last time he went to Denver, even though he had sickle cell trait, he had major complications, had to have his spleen and gallbladder removed, and so he could not travel with his team or play with his team in the Super Bowl. And that was something that we have to be aware of, and it's not I just read an article recently where some people are thinking it's discrimination against a population. But I think that we need to look at it as education of a population so that we can prevent that.
Can I just address one more part of your question? You were asking about genetic sort of counseling prior to making reproductive choices. That is one of the problems with newborn screening. Newborn screening was never designed to to find the traits per se. The traits are found as part of the screening. The screening, was originally intended to find the disease cases, but everybody finds the traits. So what do you do about it? We've always elected to inform, but 15, 20 years later, who's going to remember that? Who's going to act on that? So I think sometimes people, forget that that the trait was found, and in some families it's just not discussed. It just doesn't get talked about. It's not a priority. And I'll even say that the letter we send out is intended to be relatively reassuring in the sense that this is not disease. We're trying to explain the difference between trait and disease.
But its potential to be disease is great.
Well, trait doesn't
Trait-
become disease.
Trait is not
It
disease.
partner does.
Right,
But-
your child.
We're talking
But
about
we've
reproduction.
never intended to try to affect, the reproductive outcomes of it. There is that potential, though, if the parents are unaware of their status and you get a baby with trait, it behooves them, for both of them, to know what their status is before they have another child together.
Because the potential is both of them could still have sickle cell trait and still have, because of the ratio of genetics, they can have one baby with trait and the next one have disease is what it's saying. They both could still have
We're
trait.
blessed because all four just have the trait.
Yes.
Okay, we have two questions back here, this young lady, and then this young lady. Would you?
I guess mine is more of a comment. I want to encourage the mother to listen to your children because the trait also can send your children into a crisis. So be very careful, make certain that they're getting the nourishment that they need, the fruits and vegetables, drinking plenty of fluids, because it does happen. I am the trait, and I do have the crisis if I'm not watching what I'm doing, overexerting myself. So listen to your children. Back in the 70s, in Durham, Arkansas, they had no one that knew anything about sickle cell disease, and I had a very hard time. I didn't find out until my son was born, later on in life, that I had the C disease.
Oh, I'm sorry, I just wanted to ask Dr. West in his studies whether there was any indication of whether it was more prevalent in male versus female.
No, there's really no difference. It's not a sex-linked disorder, so it's pretty equally distributed between males and females.
I have a question for Ms. Hunt. Since you're a member of the adult population, what kinds of responses have you gotten from medical professionals when you entered maybe the ER or the hospital and you asked for pain medication? I understand that sometimes responses can be rather negative.
Okay, I have a sickle cell trait, and I also have another chronic condition. So it's difficult for them to determine which of the conditions I'm suffering from, because I've had doctors to say that, just as some here, say that you do not have problems with the trait. And there are other doctors that say you do have problems with the trait. And I do believe that some of my suffering is from the trait because it's so similar to what my experience with sickle cell comes from my brother who had the full disease. And I watched him suffer his whole life until he passed away some few years ago. And my suffering is so similar to his that I know. And I do have problems. My doctor is very firm with the ER staff about his patients. So I don't have as much problems as some others. But there's some of the patients that have severe problems when they go to the ER about getting pain medications because they are looked upon as just wanting narcotics, and it's very difficult to get pain medications at that time. But I'm one that I know what I need, I know what I can take, and I have a list filled out on a card of my conditions, my allergies, and the drugs that I can take. And when I take it in like that and present it to them, it's much easier to deal with the staff. And I recommend that for all of the sickle cell patients that I deal with in the organization that I am president of, that they would fill out the cards and that they would take them in with them. Because when you go in and you're in that kind of pain, you really don't want to be questioned. You really don't want to lay around for hours. And when you go in and you are prepared, then they deal with you in a different manner than if you go in and you're grumpy and they're offended by the way you respond to them. So if you respond to them in a certain way, you do get a better response from the ER staff.
Okay, we have a question.
Dr. Sassente, what do you do for your teenagers who come in, are inpatients in the hospital and then do not want to stay in their room? What sort of privileges do you allow them to have?
What kind of,
Grounds privileges do you allow them to have?
we don't restrict them to their rooms at all. Usually if they're bad enough, if the pain's bad enough that they're being admitted to the hospital, we usually have them on PCA for the first day or two, part of the disease, and first part of the crisis, and they'll stay in bed when they hurt. But after that, we actually encourage them to be up. We don't want our sickle cell patients laying around any more than they have to. Anything that makes you move around and breathe decreases the constipation that's associated with narcotic use, and also increases ventilation, because if you lay around and don't breathe deep, you set yourself up, for acute chest. So we do things like incentive spirometry on all of our PCAs to make sure that we're encouraging that. So we really don't restrict them to their rooms. If they want to go out and about, we have a teen room. I didn't show pictures of the new unit. It has a teen room and a new playroom, and we encourage them. We want them out of bed. We encourage them to go to school, if they can. When we give enough narcotics, you can't really go to school. That's not a possibility. But as much as they can, we encourage activity.
And that's another thing she brought up about, to link back to your thing about education. Anytime a child who is pre-K to high school is admitted to the hospital, one of the things, if it's going to be a lengthy hospitalization especially, the school teachers at Children's Hospital make sure they link back to that school to get their homework. If the parents are having real big problems of talking to the teachers or anything like that, our teachers contact me as well as the social worker, and we make sure a letter is sent. We make sure we understand that if they need a 504 plan in place, we try to make sure that's worked out prior to discharge as well. But knowing that they can get out of bed, once their pain is decreased, most of our kids, I can actually say, want to get their work done because they don't like being behind. Because that's one of the things is that they don't want to be different from anybody else. So they like to go to the schoolroom. We actually have a school inside of the hospital, and they make sure their work is communicated back to them. And that's from any school in the state.
Okay, we have two questions. I think this young lady's next.
Okay, I have a niece who has sickle cell. She's a twin. They're fraternal twins. One has sickle cell and one does not. And she's now 35 years. As the years have gone As she got older, she had less and less treatments, but she lives in Dallas now. She calls sometimes and she'll say something to the effect that she had to go over and get some hydration and a shot because she's in a crisis and go back to work. So, I mean, I've been baffled by that. Her mother's a nurse who works here, by the way, but we're just kind of baffled. Is that all you do now?
Good for her.
That controls that patient's pain. Everybody's pain is different. So some people, if her pain is controlled and that's adequate for her, that's excellent.
She used to have bad crises.
Right, and sometimes that happens.
And they're fraternal twins. One has it, one doesn't. It's just like.
We've got a couple sets of them.
Yes, we do. And we can also have children within a family with the same severe disease. One kid could be in the hospital a lot, and the other kid we only see during visits every 6 months. And that's something that just has to do sometimes with genetics, sometimes just how the kid cares for himself. Also, if there are any other complicating diseases that's in the other child. And so those are things to take into consideration when you're treating sickle cell disease, is that it's not, if it exists with another disease process, such as cystic fibrosis. We have a couple of kids with cystic fibrosis and severe sickle cell disease. And those two diseases, they don't have any wrong with their sickle cell disease. They have wrong with their cystic fibrosis. So it just depends on the kid, the genetics, and they can have the same disease, but they just act differently.
It's kind of interesting because I do work at Children's, but we are also a teaching hospital. So my question is the prevalence of the residents, the new guys, the newbies, is the prevalence of them just assuming because they're sickle cell and they come in with pain, is the prevalence of assuming it's just a crisis going down instead of, is it something else?
That actually is a problem, because, I mean, you want to balance people coming to the ER and getting rapid pain medicine and rapid relief of their pain versus remembering that patients with sickle cell disease can have pain for other reasons. And sometimes even when they feel like it's their sickle cell pain, it's not. And it's interesting, over the years, if you practice medicine long enough, you see everything. One time I went and sent one of the residents down to admit a patient for pain from the ER, and she came back, she goes, I cured the sickle cell pain crisis. I go, in 15 minutes, you're better than I am. And she holds up an x-ray, it was like when we still had film, and there was a needle in the child's foot, and the kid was 12 years old. You would have thought if they stepped on the sewing needle, they would have. But I mean, you couldn't see anything on the skin because I went and examined the child. There was this extra, and so the pain was from having a needle in the foot. And then we've had a couple of kids come in with appendicitis, belly pain. You think it's sickle cell disease, so you have to remember that they have everything else that everyone else has.
The question I have is there any support emotionally when you're talking about your adolescents and you're talking about your adults and just the kind of things that we normally go through? I would assume that there are some things that maybe with this disease process that they need just a little bit some more support.
I think the adults are missing that piece. In pediatrics, we have psych, we have social work, we have clinics set aside for several different things that they needed. We have dentist developmental if they're to diagnose learning disabilities, if that happens to be the case. In pediatrics, you can say they have everything. If there's a problem, we can get an answer to that problem.
But with that said, I mean, Children's is very supportive, but over the years we've improved some of that, and we're still not quite where I want to be. Now we do have a social worker in clinic almost 90% of the time. We have a social worker sitting there. We have child life therapy, which is, I really like that with the younger kids.
Pet therapy.
And pet therapy we're integrating into the clinic situation, but having child life there, going into the rooms, talking, because it's a big deal. The younger kids, you can't be stuck for blood. They got a shot and they hate every time they see me getting blood drawn.
And for the adult population, we've tried to encourage, hopefully in the new sickle cell clinic or the new adult care center, that they include those things to continue on from pediatrics, such as pet therapy, making sure that they have a social worker ready for them, making sure that they have psych. The other thing is that they have a pain management clinic for these patients to also attend, because that's a big deal in managing someone's pain and finding the appropriate medication so they can do the normal things in life. But hopefully, as a community here in Arkansas, we advocate for those things that work for adults, because adults need different supportive care from
So in other
children.
words, it could be a lot of help while you're at children's, then boom.
Well, that's
You turn 19 and that's it. Yeah,
No, 21.
I'm sorry, 21. You turn 21.
Did I understand you to
That's
say
it,
that
okay.
you're branching into an adult treatment?
We are not.
We're not.
I am a pediatrician and I'm interested in adult medical affairs.
So it's just on you, what's the cutoff, 21 years of age?
21 and children's, and that's appropriate, because children's does not have the resources and the issues become different. And we end up, with different issues and different problems.
I just noticed where I work, we notice a lot, like they're adults and they become hospital hoppers and then that history doesn't follow them.
And we really talk to the kids about that as they're transitioning out, because I encourage them to realize you have to build rapport with the physician. Going to different doctors is not going to help you in the long run.
Yeah, I think it's the fact that, they have discrimination issues, they have this, I'm in pain now, I need treatment now, and not understanding that, you have a chronic condition, it's going to take them just a little bit for, treatment or whatever to kick in, and then they get angry and they move to another hospital, and then transfusion histories don't follow them.
She's just saying that the care, because there's not the same doctors to treat the adult population, that's why some of the confusion among the adult sickle cell patients occurs, because they go from one place to the other looking for that perfect connection with the physician or a place to get care.
We're going to have one last question from this young lady.
Mine was really just a comment to follow
Okay.
on what they said. I'm Becky Patterson, they've mentioned my name a couple of times tonight. It's one of the things we do have that hopefully the generation that's starting to age out of us, you're going to see different, is Angela and Dr. Sacinti and I know, we are allowed to take our time in the room with the patient. There's none of this 15 minutes and you got to be out the door. So we have time to listen to them and talk with them and answer their questions and see what they need and do a lot of teaching. We do a huge amount of teaching to these patients. And what we're seeing is, because we're educating the parents better, these kids are not showing up in the hospital as much because mom knows what to do. We tell the kid as soon as he's old enough, first time you feel that twinge, you go tell your mom, give your medicine now. Don't wait till you're hurting big time. And because we're allowed to do that, they're getting better at managing a lot of things at home versus the ER in the hospital. And so hopefully, as they age out of us and we get sickle cell clinics and all, the next generation of sickle cell and do a good job with the adult patients. So hopefully, these kinds of things and what we've talked about is going to make the difference for that generation that's starting to hit 21 and transition out of here. It's going to take time, but I've been doing it since '98, and Angela and we both of us are in there all the time. And we really get a chance to really educate patients, and I truly believe that we have decreased the number of hospitalizations that we're seeing, just anecdotal. I wish now we had taken and collected data on it, but I think they're going into the hospital less and less, and they're able to treat and manage, and the parents know how to advocate for their kids too. Things like calling the pediatrician and saying, my kid has a temp of 101.5, and the pediatrician's nurse says to them, well, give us some Tylenol, let's see what happens. We're teaching them to say, no, remember my child has sickle cell. And usually that's all it takes for them to shift gears and say, oh yeah, bring your baby in. Yeah.
That's one of the things that we're talking about here, about nursing care. You all are the front.
And I am a
line
nurse,
people.
by the way.
Yeah,
They said Dr. Patterson, but my doctorate is in nursing, so
But
I'm
that's
a nurse
one of the
practitioner.
things that you all are supposed to be, is that bridge for that family. And I encourage nurses, that's one of the things I get on to my nurses about in clinic, is being that voice. You have to be a voice for your patient. Don't come in with a stereotype thinking because of this is what you saw 10 years ago. It's not the same anymore. Just like she was talking about how presentations of sickle cell complications, it's very different now, and treatments are different. We just have to, in this area of our state, we just need to catch up and think differently, think outside the box. Like Dr. West said, the picture of sickle cell, trying to break it down into ethnicities and race, you can't do that in such a fuzzy way, and that's antiquated now. So we have to be aware of that.
Okay, we're going to stop here, and we'd like to thank our presenters, thank our panelists. you'll just be patient with us, please, for about another 5 minutes. We'd like to make some presentations to our panelists and to our presenters, and then we'll have closing remarks that'll take about 2 minutes.